So I wanted to welcome you all to it's actually our second meeting in Charleston. But this is the first time I feel like we really have a chapter going here. So I'm really excited, and thanks to people coordinating, especially Nancy, for pulling this all together. We really sincerely appreciate it. I just wanted to tell you a little more about the Chiari and Syringomyelia Foundation. So sometimes people think, well, I have Ehlers-Danlos, so what am I doing at a Chiari and Syringomyelia Foundation meeting? The truth is, as a group of doctors and board members, we realized that Chiari and Syringomyelia have a number of comorbid conditions that go right along with it. And it's really kind of silly for us to focus our efforts on this little narrow space and just that we're doing a better job of helping more people by taking a broad approach to CSF, flow, so hydrocephalus, with Chiari malformation, your surgery can go better or worse depending on whether you have something like Ehlers-Danlos. So it's really important to take all of that into consideration when you're doing research and working with medical groups. One of the things that I have to tell you, so Friday I got an email, and it was from the National Institutes of Health and the National Institute of Rare Disorders. We have been working on this project for 2 years, and it's called the Common Data Elements. So what that is when you look at like an MRI, right? Some doctors are going to measure from this point to this point if they're looking for something. Some doctors might look at the reverse side of it and pick that measurement. And then they write the papers and they publish and all of that. And they're looking at, it's kind of like the elephant and the tail thing, when you describe an elephant and somebody's holding the tail and somebody's holding the trunk. So the goal of this project was to create a dictionary and a common language for all researchers to use when you're talking about Chiari, Syringomyelia, etc. So after 2.5 years of work, we turned in a 95-page Excel spreadsheet for this dictionary to the government, and Friday it was put up on the government website. So going forward, anyone who's going to publish or do research has to go and use those terms and those measurements, or they will not receive any government funding. So thanks to you for helping to provide funds for that, and this great team of physicians who gave up, I can't tell you, countless hours of personal time to actually work on this. It's up in the National Library of Medicine, the NIH, everybody's going to be using it. And it's an international project. So we didn't only work with doctors from the United States, we worked with doctors from China, we worked with doctors from Italy. So it's internationally accepted. So I think that that's one of the really wonderful projects we're doing this year. And I wanted to let you know, because it just came out Fridays. So if you have any questions about CSF or the work we do, please feel free to talk to me afterwards. And now I want to bring up Nancy. Where are you? Right over here. Nancy, please come up. And please welcome her, as she was the heart and soul of bringing this meeting together. So Nancy, welcome.
Hi, I'm excited to get started with this tonight. This is not something we typically see. We've heard this time and again from the numerous physicians who have seen my daughter over the years. There were little clues as she was growing up, but they were not concerning at the time. The notable symptoms began in her early teens, when, a few months after a surgery placing hardware to a fractured leg, she developed scar tissue and tendinitis, and another surgery was necessary to remove the hardware. This is not something we typically see, and so it began. Her hands would often turn white, and she would lose the circulation in her arms. She developed unusual scars and often seemed to be easily injured. Nerve pain began in her foot. She suffered pain in her knees. She often had bruises, but being an aggressive athlete, not surprising. Through her teens and into her early 20s, she suffered numerous injuries requiring several surgeries. We learned to pay close attention to the possible risk sections of consent forms because she was usually that rare person who was affected. We wondered why others were able to do things without any problems while she suffered injuries. Something was wrong. The pain in her shoulder began in college. It slowly spread over time to span across and down her back and upward into her neck and head. It was disabling at times. The circulatory problems in her arms became more intense. She began losing her grip at times and would drop and break things. Abdominal pain also began and was so intense that she would end up in the ER, even on her honeymoon. The downward spiral continued well into her 20s. By this time, heart rate, breathing, hearing, swallowing, and visual problems also presented, along with syncope. It was clear that something systemic was the cause, but countless physicians at many well-respected teaching facilities could not help her. I prayed hard. I tried to bargain with God, take it from her, and give it to me. I feared for her life, and she admitted later that she had nightmares of people driving nails into her coffin. After over 10 years of searching, the diagnosis finally came. A diagnosis that was missed time and again because providers failed to pay attention to the whole picture and focused only on their specialty, and frankly, Ehlers-Danlos syndrome, or EDS, was most likely not even on their radar. Yes, EDS and Chiari malformation, disturbing, but we were thankful that someone finally knew what was wrong and what needed to be done. That was almost 7 years, numerous surgeries, and many scary times ago. Since then, another daughter and 4 of my 7 grandchildren have also been diagnosed with EDS and Chiari malformation. This has been a journey I never would have chosen for our family, but there are many things that I've learned on this journey. I need to keep this brief, so I just want to share a few things. Many medical providers will assume that if you look healthy, you can't be that sick. It's difficult for people to understand chronic pain. Due to the collagen deficiency, scans and diagnostic procedures often fail to show what's going on inside. Medical professionals get frustrated when their familiar interventions fail to diagnose or bring relief. Those who suffer are often seen as chronic complainers instead of chronic sufferers. Patients often learn to stop complaining. No one wants to hear it anyway. I've seen the pain in the eyes of my daughter and grandchildren. In spite of their suffering, they laugh, play, and push through the pain, trying to hide their suffering. They just want to be normal. They look very healthy. Note to medical providers, educators, friends, and family, look underneath the strong spirits of these patients and believe that it's not in their head or an attention-seeking mechanism. Note to patients, know your limits and recognize when it's important to let your suffering known. There are times when the quest to be normal is counterproductive. My daughter sometimes has to remind her grandson that it's okay not to be the tough guy. Act as your own advocate and don't ever give up. Find your reason to wake up each day. The devastating diagnosis can send you into a tailspin of emotions, depression, anger, loss, hopelessness, and worry about an uncertain future. Allow yourself the time to grieve and come to terms with the new direction your life will take. Look around at those who need you in their lives and will be devastated if you let your disease destroy you. Perhaps a loved one, a friend, or even a pet. You might not be able to do a job any longer, but perhaps you could volunteer to help at a shelter, hospital, school, church, or nursing home. Illness will change you, but if you look hard enough, you may find you have many undiscovered talents. You'll have your limitations, but there's still so much you can do to live your life as fully as possible. I love the quote from Winnie the Pooh. You're braver than you believe, stronger than you seem, and smarter than you think. I'm in awe of my daughters and their families who've come to terms with the fact that the road they traveled in their journey growing up is different than the road their children will have to travel. They've steered their children away from physically damaging contact sports and found fulfillment in golf, music, mental challenges, and art. If you were to ask me who my favorite musician is, I'd tell you it's my 10-year-old grandson. The pride I feel when he plays his guitar and sings far surpasses the proud moments I had watching my children play their competitive sports. He's learned to express his feelings through music, and he shares his gift whenever he gets the chance. Find your blessings. My family has learned that what is important in life is time spent together. We cherish the time spent with family and friends. We realize that life is fragile and have learned to appreciate the days that are good and know that the bad days will pass. Through all of the hard suffering, we've learned to maintain a sense of humor and remain optimistic. We discovered that when we let our needs known, we've been blessed with many angels who have stepped in to help. I never would have noticed them before if it had not been for the illness. I've seen loving acts that I never would have seen before, whether it be my grandsons lying in bed next to my daughter, holding her hand, offering comfort as she lay in pain following a surgery, my son-in-law carrying her lovingly up to bed when she has given her all to the day and has no more strength to climb the stairs, in-laws who stretch outside their comfort zone to take care of young children and dogs during illness, or a community rallying together to raise much-needed funds. When I watch the news, I've often wondered what's becoming of this world, but after traveling this journey, I've experienced so many acts of kindness that I realized it's a wonderful world after all. I know that not everyone is as fortunate as us, and for this I count my blessings. Help each other. My daughter once told me that she never feels alone through all her challenges. There's always someone on one of her Facebook groups who helps her through her journey. There's no one who understands what another one is going through better than those who had similar experiences. Whether you're a patient in need of an empathetic ear or guidance, or an experienced provider who can offer advice to a puzzled provider frustrated with a very complicated patient, ask for the help you need and reach out to help each other. In this journey, there are many new discoveries to come, so we need to learn from each other and support each other. So much new knowledge has been learned and shared within the past few years, and through research, educational lectures, and support groups such as this, we hope that there will be a day when patients and providers will have the tools necessary to cope and care for these illnesses. I thank God every day for the bravery of my daughters and their families, the love and support of our friends and family, and the medical providers who have selflessly worked to learn all they can about these chronic conditions and tirelessly care for my family. They are my angels. I'm excited to see this support group come into fruition and see so many successes accomplished by the CSF. To patients, friends, family, educators, and medical providers, you're the village. Please join together on this journey and know that together we can hope for a future that will meet the many needs of all those suffering with these disorders. Thank you. And now I have the honor and pleasure of introducing Dr. Sunil Patel, our expert speaker tonight. He's a neurosurgeon here at MUSC, Should I say the whole works? Okay. He earned his medical degree from USC. He completed his internship and residency in neurological surgery at the Medical University of South Carolina, as well as fellowships in microneurosurgery and skull-based surgery at the University of Pittsburgh in Pennsylvania, and cerebrovascular surgery at Nagoya University School of Medicine, Japan. Say that right? He's affiliated with the Medical University of South Carolina and Ralph H. Johnson Veteran Affairs Medical Center. He's a prolific researcher, having been investigator in NIH-funded research on hypertension and several clinical trials. He has authored a multitude of peer-reviewed publications. He is board certified by the American Board of Neurological Surgery. And most important to me, he fixed up my grandson. Thank you, Dr. Patel.
Thank you all for coming to listen, and thank you to the foundation for setting up the local chapter. I'm hardly an expert on EDS. I just wanted to let folks know that. I have just entered this world through the most important people I come across, my patients. So what I'm going to talk about very briefly is how I came to know about EDS, and through some of the diseases that I treated as a neurosurgeon. And I can frankly tell you, I was one of the providers until 2 years ago that would have thrown a patient out. Said, I don't believe you, you have something I can't treat, I don't understand, etc., etc. So, Chiari is where it began for me. It was my introduction to EDS. And there are many, many people that I've met in the past 2 years since my awakening to EDS that I realized there's an entire new world of things to learn about. And there's a lot more to learn to be able to help these people. And that excites me because as an academician, I can get quickly bored by the same thing over and over again. But when there's something unknown and there are lots of patients suffering from it, it becomes for me something that wakes me up at 5 in the morning, and I'm excited about it every day, 7 days a week. So Chiari, what is Chiari? This is what it meant to me for the first 20 years of my career in neurosurgery. And if this is a little too detailed, I apologize. You know, I'm trying to think about how to talk, but I like to speak freely and how I'm thinking. So Chiari is where the cerebellar tonsils are dipped down, and some people have a syrinx. And the thinking among neurosurgeons is simplistic. You know, neurosurgeons are very simple-minded people. And we don't think complex, not usually. Or we try to simplify complex things. That there is just an impaction, and therefore spinal fluid is not flowing, and we had all kinds of explanations. So yeah, you know, it's like a cork, and the pressures above and below don't communicate, and that's how patients get symptoms. And the symptoms are headaches and everything that goes on in this area. This is the brain stem. So some people had arm and leg symptoms, and etc. But if they start talking about crazy stuff like I got numbness somewhere or in my leg or the blood pressure is not right, you don't make sense to me. This is not here. And we would treat this, and the typical way to treat this in neurosurgery was just to make more room here. And of course, if you ever read up on Chiari surgery, there's umpteen different ways to do it. And even in my 20 years practice, I evolved into 4 different ways of doing the decompression. But this is what happened. I went into this. I did a Chiari decompression, and I found out that 20 after half the patients, and these are sort of literature, but this was my experience, similar. You know, if I wanted to feel good about myself, I'd only admit to 20% failure, but sometimes I really was honest with myself. And, you know, about half the patients came back with continued problem, or they got better for a few months, a few years, and they were back. And you got a picture and said, there's nothing wrong, your Chiari's fixed, right? There's nothing wrong with you, go away. And that's what happened. I'm just being honest, right?
That's good.
Yeah, go away. But that wasn't enough. And then you run into a patient, or you run into other colleagues who are facing the same thing. So what's going on here? And then you talk to somebody in another world who's treating EDS, and then there come neurosurgeons treating tethered cord, and we'll go over some of these things and see, does this all fit together? And you go back to the history of this patient, and maybe they had a trauma that started their Chiari symptoms, or you really dig into it, you really sit with the patient, you listen to them, and all along through their childhood, they did have hypermobility or joint hypermobility. This wasn't my vocabulary until 2 years ago, so I'm going to have to dig into your government vocabulary and get it right. But thanks to folks at the CSF who put neurosurgeons together, and I actually attended my first consensus meeting 3 years ago, thanks to one of my senior colleagues, Fraser Henderson, who's in Washington, who sort of caught me by the ear, and I was junior to him, so I had to listen to him. He says, come here. You're asking questions that I asked too, and you might learn a few things, and I have, and I'm continuing to learn stuff. So something else is going on in these patients, and what is it? Well, here's this patient who has a classic Chiari, but this one also has a Chiari, but there's something else they have. And we start looking at the joints of the craniocervical junction, right? There's more than just the brainstem and the cerebellum there. There's joints. Where the head connects to the neck is one of the most complex joints. Imagine this, a pumpkin on a peg. And that joint is supposed to move in every possible way and yet protect the most important real estate, I think. Well, everything in the brain is important, but the biggest highway here is the brainstem. And so to have the brainstem sit inside a joint that does all this, and do it without hurting or without stretching the medulla or without bending it, that's an incredible joint. And you can imagine if there's any different motion at that joint, if say looking back and forth it does this, or it twists a little too much, then you're going to put undue traction on the entire central nervous system. And there's a lot of stuff that happens in the entire spinal cord and medulla. Blood pressure control, sensory symptoms, motor symptoms, visual problems that you can get because everything's tied together, balance problems. So maybe my Chiari, so this patient would have gotten a Chiari decompression from me, maybe gotten a little better, but they would have come back because I missed out on the fact that there is a little bit of a kink in the medulla. And the kink comes from the fact that they probably have a hypermobile joint there, or they've got tethering way down below. So I think I entered into a world of even more confusion. But something important happened, at least I asked, right? A question arose, what the heck is different about you? Sit down. You look like a normal person who had a normal job, or they're a teenager or going to college, everything was going fine, and suddenly you're crazy? It's not possible. So this is how I came to learn that there is a Chiari, but then there is a complex Chiari. And it's this complex Chiari, my 20%, 25, 30% failures, that I really need to focus on that they have something else. And that's how I got introduced to EDS. That EDS, there are patients who have EDS that are hypermobile joints, and they do affect my corner of the world. When I learned about EDS 30 years ago in medical school, I read the chapter, which was probably half a paragraph, and I said, not interested. I'm interested in the nervous system. I'm interested in the brain and the spinal cord, and I want to become a neurosurgeon, right? I don't need to learn about EDS, just like I didn't want to learn about the gut, and I didn't want to learn about the heart. I just want to learn about the brain. But it turns out I need to learn about EDS, because EDS affects my organ, right? Of course, EDS patients have a lot more things going on than neurologic, but as a neurosurgeon, I come into it from the neurosurgical perspective. This is just one of several, so I can't do this in half an hour. We would have to spend days and days and days talking about the overall EDS. But just to show you that I started to learn more about the joints themselves. So I'm a little bit now a spinal orthopedic surgeon, learning about this complex joint between the atlas and axis and all the ligaments that put those joints, the very ligaments that are affected in EDS patients, right? Abnormal collagen, the ligaments are lax. And I started learning about what are the degrees of motion between these bones and what's normal and what's not. Well, we're still putting that information together. There's a wide world of acceptance on what is normal motion and what's abnormal motion. We don't even have normative data on some of this stuff, but we're beginning to learn it. And I think as people like me from all over the world gather, we're beginning to show each other what we think is abnormal and trying to gather data on normal people or people with normal ligaments and try to figure that out. But I never thought about rotational degrees of freedom because I thought, that joint's supposed to do everything. But when you really study how C1 and C2 rotate on each other, there's now a clear understanding in my mind what's a normal rotation, what's an abnormal rotation. And a lot of that data comes from trauma, but now we realize that EDS patients can have this too without any significant history of trauma. Just another slide showing that you can also have settling in some sense. Not only do you need specific kind of, but you can have settling where the head can settle down, and we used to call it basilar invagination. And when you look at the MRI, they don't look like that basilar invagination, but when you do dynamic films on the joints, that's where you learn and say, this person has abnormal motion between those joints, very complex joints. This is something that a good friend of mine in India showed me about 15 years ago. Sunil, what's this? Why is this joint settling? I've done a Chiari decompression and I've fused them. I said, did they do well? Yeah. His name is Atul Goel. He's in Mumbai. And I called him back about a year ago. I said, I think I found your answer. All those patients you were showing me, do you keep track of them? It's India. Give me a break. You do surgery, they're gone. I said, well, if you can get their families, I think you may have seen one patient among the entire village of patients that actually have EDS. And so, he sort of graded this hypermobility. So it seems like this is all over the world in very severe forms of it. People with significant EDS that were missed, and we're busy trying to, give them various names, but all these patients have, in my mind, I think they have a form of Ehlers-Danlos syndrome. And it would be important for that family to know that. Well, here's my second venture with EDS. So this is just going to be stories about the neurosurgeon meeting with this disease. I treat a lot of cervical spine problems. And this patient came to me about 4 or 5 years ago. Now the patient's treated because since I understood it, brought back. And brought these films to me and said, I'm having myelopathic symptoms. Myelopathy means symptoms of spinal cord dysfunction. Well, to the dumb neurosurgeon, you get dysfunction from the spinal cord if you squeeze it. Show me where the spinal cord is being squeezed. It's not being squeezed here. When I looked at that film, I said, you know what? I don't know what it means when you bend the spinal cord. I suppose it has to bend. Well, not true. You can't stretch the spinal cord, and you can get symptoms of stretching the spinal cord. Now, I knew a little bit about that because I treat spinal cord injuries, where somebody has a spinal cord injury and you get an MRI of the cervical spine, and no disc is herniated out and there's no fracture, but they had near complete paralysis that got better. And we used to think, well, maybe the spinal cord got a little stretched and it's fine. But this turns out to be an EDS patient, and what this patient is doing is all their discs look pretty healthy, right? None of them are protruded out. But guess what? The spinal cord here is stretched, and if you draw this line like that, and I couldn't draw it on here, this line stretches, meaning the spinal cord stretches. And we know from the laboratory, 25 years ago I did work in animals to show that if you stretch the spinal cord, it's just as bad as squeezing it or transecting it. So you have an EDS patient who I missed 5 years ago, who came to me with these myelopathic symptoms. They would lose their balance, their arms and legs would go numb, and I sent them out. I said, Not me. I don't know what to fix there. What did this patient have? They had hypermobility in their neck. And now I'm even learning more from colleagues like Susan that if they had good neck muscles, if they had good postural training, they could prevent this stretch. To the dumb neurosurgeon, I needed to correct this, quote, deformity. But you learn things if you keep your mind open, and I had to keep my mind open, that this patient has a cord tethering and a cord stretching, as I call it, and that gives problems. And there have been people who actually have had quadriplegia from this kind of thing. And when you look at their spinal cord, if they, we had 2 autopsy cases. If you looked at their spinal cord, and you section it and look at it under the microscope, their axons were broken because of this overstretching of the spinal cord. So this is what happens in EDS patients and unrecognized, right? You go to the spine expert, and I do a lot of spine surgery, and I'd say, yeah, you got a little hypermobility there, but I don't know. But they're tethering their cord, they're stretching their spinal cord. So that's another thing that you see. This is another thing. So now, what EDS did for spine surgeons is they made us start to think about the dynamics of movement. Craniocervical junction, Chiari patients, cervical spine. And so now, when I get somebody who's got a neck like this, and this is in the normal supine position, and MRI is done laying down. Now, if they have a normal MRI, but I'm listening and I'm writing and I'm saying, that sounds myelopathic, I don't stop there. I say, let's get some bending x-rays. And sure enough, you bend their neck back and they're buckling their ligaments, they're overly stretching their neck and buckling their ligaments, and they're squeezing their spinal cord. And very, very young people like this patient became myelopathic and had balance problems and couldn't dance anymore and do all the things that they wanted to do. And that's because we now understand, by getting flexion extension MRI scans in the standing or sitting position, you can actually diagnose the problem. And she does have EDS, and it turns out her diagnosis of EDS came through a neurosurgeon, because before that everybody was treating their joints and their dislocated shoulders, and you all know the number of things that you live through. So she's doing fine. But more important, now that she knows what she has, imagine, now she's figured out what to do. And you direct them to a therapist, and you direct them to the right people, and you say, all right, this is the things you need to avoid. Doesn't mean you don't enjoy life, like you say, your grandson plays guitar, but they continue to enjoy life differently. And obviously what is that incredible sport young people get into? CrossFit? Yeah, we had to stop. What is that, CrossFit? Yeah, we had to stop this young lady, but that's okay. It didn't ruin her life. She's much better now. So she has instability in her neck that we would not have known about. Her discs look normal, she's a myelopathic, and when I saw that patient, now that I know about EDS, I said, okay, we need to do something about it. I probably wouldn't have done this surgery on her today. I did it 2 years ago because there are other things that this patient probably should have gone through with physical therapy and all that. And I'm not trying to knock on physical therapy. I've already knocked myself down enough, so I'm going to knock some of my colleagues. But even the physical therapists, not all of them are very, very completely aware of how to treat these patients. It's completely different than normal disc disease and normal hip problems. And they have to have better knowledge. Very few people have it. If you look at the neck, you're looking for pain in the upper arms, and you're looking for nerve compression syndromes and sensory loss over the shoulder. But in the EDS patient, it's a lot of different other things going on: headaches, nausea, breathing issues, poor visual accommodation, gait problems, imbalance. And this one makes sense to me because now I know, because of their hypermobility, they're stretching their entire neural axis, right? From tail to top. And the top has everything to do with headaches, the nausea, from the medulla, breathing issues, because of the fact that they're probably affecting the function of the medulla from this excessive stretch. And same is true with visual accommodation and gait problems. So I've learned a lot and I'm continuing to learn a lot. And I think it's because the patients have taught me to listen to them. And hopefully I can help. I don't know whether I can help everyone, but it just helps to know that I need to look for this. When I can't figure the usual answers, I need to look for that other stuff. And there's a ton of stuff. And we're adding more knowledge to the cervical spine dynamics, something that I never paid attention to, but now we're busy gathering other data. So the spine experts are now with me and a couple of neurosurgeons who are involved in the spine societies are saying, you know what, let's collect normal information on mobility between the joints, and for each various age. And so if we see a 5-year-old and we see a 10-year-old and we see a 20-year-old, we can measure all this dynamically and say, is this more or less, or is it within range or not? This is just one slide I pulled in to show that that data is now being gathered. Thanks, I hate to thank the disease, but honestly, all medicines, learning about the body came from disease, right? And so this is a disease that's teaching me a lot about managing these patients that I see with spine problems and cranial problems. So clinical instability in the mid-lower cervical spine, we've created this, and you don't have to go through this, but it's, again, based on learning more and more about hypermobility syndromes affecting the cervical spine and craniocervical junction. Here's another patient with a syringomyelia, and we would have completely ignored the fact that their medulla is kinked and they have hypermobility. We would have probably treated the Chiari, put in a syringosarachnoid shunt. Maybe they got better a little while the medulla is constantly being kinked by the craniovertebral hypermobility there. Again, another disease that I've been treating for 20 years, and I've had my failures, and you know what? When we gather at meetings, I'll be honest, we're drinking a beer or we're at the bar and we're saying, syringomyelia, oh yeah, those patients are crazy. You just shun them and send them out. If they get better, fine. But then I brought this slide up because this is a patient of mine. And in the past 2 years, now I see a patient with Chiari and a syrinx. I'm like, whoa, you might have something third going, and I'm busy working up their hypermobility before I even tackle this other thing. And you know what? I've seen it. There's a patient in here who just told me they were diagnosed with Chiari. Every year I see 3 or 4 patients with a radiographic Chiari but no symptoms. And I started getting bending films on them and they have no hypermobility. So my world has flipped. This is not Chiari anymore. This is a patient with hypermobility first. And if they have a Chiari, it looks like a Chiari. So Chiari is a radiologic diagnosis. Radiologists don't make clinical diagnosis. They make picture diagnosis. But I see a lot of patients with Chiari and syrinx, no symptoms. And there's no medullary kinking, there's no hypermobility. In other words, Chiari and syrinx may be just a normal formation of the central nervous system. It requires this something else to take them over the edge. Now I can tell you, if all of you are neurosurgeons in this room, and in this very room I said this, and there were 12 guys sitting there, I had to duck. You're crazy. You're changing everything we're taught. Because on the American Board of Neurologic Surgeons, where I'm also an examiner, I would flunk somebody who says, well, what are you talking about? Hypermobility, this, it's, but that's okay. We live and learn. And we're going to change everything we know about Chiari and syrinx and cervical myelopathy, because there is something else going on, and it's the EDS patients that have taught me. Here's something else, tethered cord syndrome. So what did tethered cord mean to me before my first EDS patients came to me? Tethered cord simply meant, well, the tip of your spinal cord has got to lay lower than L1 and 2, right? Because the spinal cord, when you're a baby, is sitting right in your sacrum. And as you grow, the spinal cord doesn't grow, and so the spinal cord starts rising in your spinal canal, and at the tip of the spinal cord is a string-like thing called the phylum. And if the phylum is very tight, then as you grow, the spinal cord doesn't get a chance to come up. So it's below the L1-2 level. So you have patients with bladder symptoms or low back pain or low-lying conus. And on an MRI, they've got a thick-looking phylum like that. Okay? You say, oh yeah, you've got tethered cord syndrome. Then you get this patient who's got the same symptoms, but the spinal cord is not low-lying. It's at L1-2, and the phylum's not thickened. But they've got all the symptoms of the tethered cord patient. In the EDS patients, they've also got cranial symptoms. They've got headaches, they've got myelopathic symptoms. Well, what's going on with them? Well, until 3 years ago, go away, right? I don't know who you are. I can't treat you, I'm sorry. I'm not that rude. I would usually package it nicely for them and send it on. You know, but thanks to some of my colleagues who were probably brave, they sectioned the phylum because they had this clinical syndrome of tethering and their symptoms got better. And some of us took out the phylum, and I've done that too, and found out that the phylum I took out of the EDS patient with tethered cord syndrome with a normal lying spinal and not an abnormal, an MRI abnormal phylum, if you looked at it, the phylum in an EDS patient looks completely different than a normal phylum. And contrary to, you would think EDS, everything is kind of lax. The phylum in the EDS patients tight like a real string, like a nylon string. It's not supposed to be that way. So EDS patients have tethered cord syndrome, and it's all due to the histology. Again, this is a clinical diagnosis, and there's a Hopkins pathologist who collected 19 normal phylum, and I think about 12 or 13 EDS phylum. And sure enough, consistently, and I think she published it in the pathology literature. So for me, what that meant is every EDS patient has a tight phylum. And what do you do with that? If they get symptoms from it, then they probably have something going on, and their phylum is causing a tethering. Lots of publications on occult tethered cord syndrome, and all these guys were poo-pooed. If you look at the publication 1990 to 2012, I know 3 of these guys, and they were all poo-pooed. Crazy. You're not, but it's there. I told somebody else that there are well-written papers even 30 years ago. They're ignored because nobody else is publishing them. Nobody else believes in them. You're not mainstream. And you know what? Let's face it. Physicians are a little ego. If we don't understand something, we'd rather say you're wrong than I don't know, right? But I don't know, if I don't know does not lead to a question in our minds, then nothing will happen, right? Because I've got the next patient to see who I can treat. But I've changed my mind for the patients with these things now, because
you're a practitioner. You're
right,
practicing
right.
still.
The problem is, how many times do you say I don't know? It gets tiring. So after 25 years saying I don't know to 20% of my KRA failures, or probably 10-15% of my cervical myelopathy patients who probably had some form of hypermobility syndrome or EDS, it gets tiring. And say, this is not satisfying. And they walk out of the room and you're like, it's deflating. It's like, damn it, something's wrong here. And they're not addicted people. They're not crazy. They seem like people in normal social structures, etc. So something's going on. Now this one I don't know anything about. This is my newest venture. EDS patients with mast cell disorders. I've had these patients that have some sort of autonomic thing going on. And I could only put up one slide because I said I can't talk intelligently about this. Until 2 years ago, there was a mast cell expert at MUSC, but at that time I hadn't woken up to EDS. Now he's gone, and now that I've woken up, he's gone. So I'm sort of left here at MUSC without a mast cell expert. But this is something else that I wonder if some of the EDS, and what its link is, overall link is to the autoimmune stuff that goes on in these patients, in their GI system, cardiovascular system. I have no idea, but I think there's something going on. I see them with flushed skin sometimes, episodes that occur, and some of you could write a book on it and teach me, so I hope to be able to learn from some of you. The other thing that I've seen in some of these patients is these unusual vascular symptoms, call them TIA-like symptoms. And these patients have TIA-like symptoms, and they seem kind of young, and they're not old enough, they're not smokers, they seem to have healthy diets, their cholesterol's fine, they never had a heart attack. And you study their blood vessels, and carotids look fine, vertebrals look fine, and they're taking aspirin and go away, we don't know what happened to you. And there are 3 patients that I have now that I decided, I told my angiographers, I said, do the angiography, turn their head to the right, do the angiography, and turn it to the left, do the angiography, and measure the caliber of the vessels. And sure enough, when they were turning their heads, they were squeezing off the vertebral arteries. So that's how they're getting their symptoms. That one's easy to treat, right? No surgery. You just send them to Susan. Hey, Susan, give them a little lecture on how to hold your head straight and not do crazy things. But that's the thing, there are so many patients with hypermobility syndrome around us, then we know it. And I think as the genetics get worked out, and as more physicians learn about this, and more therapists catch this, and there's a little more communication, we'll probably gather more of these patients, and hopefully as we treat them, we'll also learn more about the variety of different things that can happen with arterial kinking and that sort of stuff. Oh, a little bit on mast. I'm not going to talk on mast cell. I don't know jack about it. But, sorry, old French, it's almost 7 o'clock. So here's some of the things that I've come across in these patients. Each of these is a neurosurgical disease treated separately for other things. Okay? And every one of them, except this mast cell stuff, every one of them I have seen separately as diseases on their own, but every one of them are very difficult to treat. And now I put this list together because it says, what are all the things that I've treated in the past 25 years that I've not gotten 100% result on? And I've scratched my head but ignored it because it must be something else. And I wonder if this guy here is the culprit. In my mind, I believe it may be. And I think if more of us who treat these individual diseases have these failures, we should ask, I wonder if it's EDS, because if it's EDS, we need to put the whole thing together and figure out a different way to treat it. So this is me, It'll keep raining questions for me, but I'm learning so much. I'm learning so much about human physiology from this, and hopefully helping.
You haven't jumped.
Huh?
So, yay.
No, just pondering. I haven't jumped, no. Definitely not jumping. So that's what I had today. I sort of put together how this neurosurgeon in this small southeastern coastal town has come across this syndrome. And it's with the patients that I've treated here that I have to be honest, I may have ignored, I may have misdiagnosed, but in the past 2-3 years, I've learned enough that this is real, and I've been able to help many of them. Not all of them. They're very complex patients, and each one's a different story. So, thank you. It's informal. Y'all can ask.
Does anyone have questions?
Yes.
Yeah. As an employee who works here, and putting the pieces together, how do we go about getting maybe what we're lacking? And you said that other person that was there and is no longer here that studied something. I mean, is there something that, Dr. Cole preaches are, wanting to heal the whole patient. So is there something we can do to look at the whole patient somehow, something? I don't know. I'm just, every time I go with her to an appointment, I think about the whole patient.
Yeah. No, I agree. And I not all, there are many more like me. I'm sure there are patients that rheumatologists have here or gastroenterologists have here I was fortunate enough that what's that?
It's just getting them all together. on the
Yeah.
same page.
I think one good idea that came from her is maybe having more, the idea was, why can't we have grand rounds where everybody's in so grand rounds are still very focused, neurosurgery grand rounds or rheumatology grand rounds. God forbid those two groups sit together in one room.
The groups that come in eights, and you have to say, excuse me, can you actually break that down where this young girl can understand what you're talking about, her mother?
Right.
And there's that one also.
Yeah, I don't think things will be organized overnight to say, all right, we're going to have EDS clinic, where the ideal thing, here's the ideal thing. Let me talk about what the ideal thing would be for these patients. You come to one clinic and there's everybody from a neurologist to a rheumatologist to a gastroenterologist, cardiologist, neurosurgeon, everybody who has an interest. There are very, very few centers. I know there's one in Europe, in England, but there are places that have slowly cobbled that together and have done that well.
Well, maybe we can change what's possible.
We can change what's possible. I think we have to have a few more sessions like this, maybe start talking to people,
That is our
the other experts.
changing the possible
Right.
and what we
Have-
can do to.
Have an actual symposium. Maybe this kind of thing can be in a more formal way at the College of Medicine level with physical therapy and everybody coming in to say, all right, and talk about cases. We learn case. I constantly learn case by case, and grand rounds is exactly that. Somebody gives a big lecture. The nicest way to learn is you take one patient, you speak their whole history, their whole examination, present it to a group of people, and say, all right, what does everybody think? And I think that may develop a groundswell of folks. The old-fashioned rounds at Mass General, we're talking in the 1800s, 1900s, used to be that. You actually brought the patient, and one physician examined them in front of the entire group of physicians, and everybody interrogated the patient, and then everybody was shooting, I think it's this, I think it's that. But that's what they did, and that's how they learned, and that's how they realized that this might be something. But in a situation like this, I think the only way maybe to hold more symposia where we invite people. I now, because I've been seeing EDS patients, have formed some links with some therapists and, hematologists, a cardiologist who's interested in POTS, which is something I've never brought up, but, I didn't even include POTS there because I've never seen a POTS patient to begin with, but now I see these EDS, you have POTS. I said, I know what that is. So I also know a cardiologist who is interested in autonomic disorders, who enjoys seeing these patients. It's sort of his little pet thing, his hobby, and which is great because that's what you want this to be. You want this to be something that the physician is just incredibly interested in. And
like you said,
and then you put
kind of move along, okay,
Right.
and then we're going to come back together and discuss what's the best option for
Right.
this patient,
And-
because patients walk away frustrated.
Right, I know. The other thing that
It's
it's not unusual when you have a complex thing like this that affects the entire body, that you may not find that single physician who can own everything because, let's say a rheumatologist owned this, and what's the professor, what's his name in England? Graham. Professor
Rodney Graham.
Rodney Graham. So he looks like he's a guy who owns it. But, I talked to him and he says, no, I don't own this where I am. The patients, all these physicians are interested in come and they own their piece. Because, the rheumatologist is not going to want to deal with cervical myelopathy or craniovertebral junction. And I'm not going to know enough to deal with
You're
the
owning
GI.
a lot more than some of the physicians around here.
Right, so I think collectively, if we learn to communicate with the electronic medical record system, it's been very much easier for me to take some of my adult EDS patients and I'd send them to Jim Glenn cardiology and a week later, and so what he said, and I'll email him and say, I got this, and this, etc. So I think I just emailed the hematology department 2 nights ago. I have a patient who has EDS but may have some mast cell disorder. I've read enough about it to perhaps even ask the question, who is your mast cell person? If not, appoint one. somebody who can just say, you know what, this is gonna be my baby. I'm just gonna see patients with this, or at least, you know, somebody I can send because they need to see more patients to learn more. Right? Because I can't send that patient just for their mast cell disorder all the way to Baltimore, you know, and then come back. The communication
People are
becomes.
willing to travel
Yeah, I know,
from wherever
but-
to come to a
And
doctor.
you know, the difficulty there is, so you go to Baltimore for that, and you go to this place for that, and the communication becomes very, very difficult for people to, and those who are fortunate enough to afford to travel will do it, and they'll carry all their films and all their records. CD, disc, I've seen piles on my desk, and it's like, okay, I need a weekend with you, you know, go through all this. Yes.
So as a physical therapist, I've actually been lucky enough at my young age to have 4 patients recently with EDS, and one of them was a physical therapist that kind of opened my eyes to it. And is there, you know something's off and you know something's wrong because they're not responding. You see we see the hypermobility first because that's what we're trained to recognize their
Yes.
movement patterns. So then you're kind of stuck in that hole with where do you know that you got to get them in somewhere, and you're pushing and they don't get where they need to go. Is there somewhere you recommend starting?
In terms of
Like
not
to get them in with like neurosurgery? Do we start with their primary care provider and still keep pushing?
I mean, if you think it's a spinal kind of thing, I'm happy to see them. But I've seen people with joints and stuff, and then I'll send it to an orthopedic surgeon who's starting to understand it a little bit.
Is it bold to say, hey, they're having multi-system instability, there may be something else going on
Right.
here?
Yeah, and they need
Yeah.
and for me, the genetic thing comes from the Greenwood because we don't have. So
Right.
I call the Greenwood people, and I've been here long enough. One of the advantages I have is there's 650 contact numbers on that little device there that I quickly either text or email and say, look, I've got this patient, would you see them for this and this and that. You know, I speed dial sometimes. Sitting in the back there is a therapist. I hope I don't mind you pointing at you. Susan is also a physical therapist, has EDS, has lived with it, has successfully lived with it, I think. Very, very active person. I'll often ask her, say, what
Yeah,
do we
and as a
got?
PT, I think your biggest thing is you have to prioritize, and that's what you need to work on. Otherwise, you're going to be lost. You're going to be like, oh my God, you haven't seen this specialist, you need this specialist, you need that, because there are so many issues. But as a physical therapist and looking at what we can treat as a physical therapist, that's what we have to concentrate on.
Right.
So when you look at the hypermobility, where are the problems? Are the problems in the spine? Are the problems, in the hips or the shoulders or the fingers? And you have to kind of prioritize from there. And then as you're doing exercise, you may catch on to the POTS being an issue, and then you see how much that's intruding on what you're doing, and then you reach out to that specialist. So,
And as a physical therapist, you can't recommend somebody to go to a certain specialist. You have to get their primary care physician to do it.
exactly.
As a patient, though, I think that I would want at least to hear the name. You say, I've seen some patients like this, and, however you would put it, because you might know it, although you can't technically diagnose it. If you're not diligent enough as a patient to go find somebody to give you that umbrella of a diagnosis, then you're lost again.
And don't you would normally send some kind of notes to whoever referred that patient to you, right?
Right, of course. Yeah, we
You said you feel kind of bold to say, I think this might be going on, but
Right, we
they're
can't
relying on
diagnose,
your
but we can-
expertise as well. You can just
Right.
say,
Yeah.
there's a little something.
Not only that,
wrong
we
here.
need your expertise to do some of them because sometimes they're at a loss. We really want to give us our muscles.
Yeah.
And they use Facebook a lot for who's the doctor who's going to listen. I mean, Facebook is huge
Probably
in this
that's
network. Because who did you see that, might have
Yeah.
listened?
It's true. I mean, even as a therapist, you feel, but I also feel like, what do I do with this patient who got sent to me by their primary doctor for a cervical spine problem, but having seen enough EDS patients, they've got some other stuff going on. You know, they've got some vascular stuff going on, and it's an awkward spot, right? Because I'm pretty sure they've got that, but that's not my area. And what do I tell the primary care doc? What is it my business to tell them? But lately I've been a little bold, you know, I'll put it in a paragraph in a note, and if I know them well, I'll text them right away and say, you know, I saw them for a cervical spine, here's what I think they may have EDS, I think you may want to send this patient to so-and-so and so-and-so, and just, you know, turn it around. And if they're responsive, if they're not a primary care doctor, right? But you know what? The patient is the best primary care physician, I think. You know, of course, they care for their own body, right? So they're their best doctor. So you can, even as a therapist, you can say verbally to them, you know, I think you may have this. There are certain experts for it. You may just want to keep a list of names, and I don't know, maybe we could create a network of names of specialists who in neurosurgery or cardiology or hematology.
We've kind of got one going in the Charleston group a little bit. You know?
Put these names together and then share it among all the providers, including our therapists, to say, you know, here are the people who know something about EDS. At least they.
Well, that's where she ended up with Dr. Head.
See, well, what was kind of great about going through the internal medicine, where you got a different doctor each time, I had to learn through my group who I needed to go see next. So you go into, and you got, and I'm like, okay, well, I need a referral to this doctor, I need a referral here, I need a referral here. No, I don't want to see that doctor, I heard he was mean, I want to go here. You know, and then they're good to go on the page, and you say, okay, these doctors were nice, and these doctors didn't know what they're talking about.
You as a patient have to be your own advocate. I mean, I'm going through some cardiac stuff right now. What do? I emailed Dr. Patel and said, okay, you know, who do I see? Or, you know, who would you see for this? And so, but my primary doctor wanted to send me to a women's cardiologist who specializes in women's heart disease. And I said, but I'm going to walk in there and it's going to be a waste of an appointment.
Yeah.
So, you know, as an advocate for myself, I'm the one that I'm responsible for educating myself. And then as a PT as well, I did PT school 20-some years ago, and I walked off with those migraine headaches after doing therapeutic, exercises and going, oh my gosh, you know, what have I done to myself? Or even modalities and traction. I didn't know I had EDS then. Walked off with a migraine for 12 days, throwing up after doing cervical traction, you know, and just practicing on each other, things like that. You know, it's not straightforward physical therapy anymore. It's not what you do with your traditional patients. It's you have to have a physical therapist who is really going to listen to you and listen to everything that you have to say and be very sensitive to what you're saying. And that's the only way it can work. And then you've got to work with the doctors as a team, you know, and also be an advocate for yourself. So it's a lot of work, but well worth it, and you can be very healthy and you can live a very, you know, good life. So.
Yep. Yes.
I think a lot of the times it's like, okay, your primary care doctor is treating you for this orthopedic doctor sent you for this. Now I'm seeing you, and it looks to me like maybe you have EDS. Where would be the first place? Would it be a genetic specialist to get a diagnosis? Because they might go back to their primary care doctor, and their primary care doctor knows nothing about it. And doesn't believe it exists.
First, second,
Same with
third.
the orthopod. Would you send them to a genetic specialist?
I think so until now, I have not seen my first, oh, you might have EDS. You know, they've had a multitude, they've said, I have EDS and I have these problems. But two of these patients that I brought back, I sent them to Greenwood Genetics to confirm that they have it, and they both have it.
Okay, so that would probably be the best recommendation.
Yeah, if you have a new
provider.
patient.
Sorry, I don't have EDS, but from what I've gathered, you know, it's through your family history. So you have, that's genetics is gonna go through that. I mean, as soon as she walked in.
And
it's
some of
like,
them it's very
your
obvious,
history.
you're right.
There's
When I
no
saw
test
her
for
grandchildren
hers.
and, you know, you see the mother and say, okay, that's a waste. You know, I wouldn't send to Greenwood Genetics there because there's already a history of it. But you see a de novo patient whose history is either not available or they don't know enough about whether they have any wonder. Some of them, however, you know, if you're right, if they
I
have
mean,
a
I
childhood
started
history
in a
of,
dental clinic. I mean, in the dental college with Dr. Gonzalez.
yeah.
That's where we first heard the
I
word
was her,
EDS.
oh, you
and
might
that's
have EDS.
a year ago. So,
It took a year to get a diagnosis, so.
Did you have genetics?
She's like, you might have
It's
EDS,
just-
go out on your own and figure out where you're gonna go. I'm like,
And I had genetic testing after a stroke and then was pregnant several years later, and then they were concerned that I had type 4 vascular, EDS, so they wanted to rule that out, and so they did genetic testing at CHOP up in Philadelphia, and they said, well, you don't have type 4, but we definitely see, because there's no genetic marker, I guess, for just hypermobility, so they
More
moved into
family
everything
history.
pointing to classic or hypermobility.
and what she did, she wrote down the family, more than the family even recognizes. Once she started writing down her family and the things that happened, it was just
They don't
there.
remember.
And the family are like, it's not on our side of the family.
Yeah.
No, it's not on our side of the family.
And it can go through, I have 4 brothers and sisters, and, I look at some of the symptoms are real mild with them, but I'll be one that just really stands out. And then I look at my mother, and she's got some symptoms, but not,
Yeah.
Because
I planned them
a
and fully
50-50,
diagnosed
you
them.
may, or it's a 50-50 chance. You may
And we
get
go back
the
in
gene
family
or-
history, we're like, oh, well, we think it's a great aunt from Hungary, that when you look at these pictures, then you go back to the pictures, it's like, oh, well, that's where who knows,
Yeah,
but
yeah.
again, it's treatment symptoms.
You want to make a comment on that?
So it's really interesting. I just want to say this. So there are suggested scales and things in
Yeah.
the 95-page document that we submitted. And then from this whole thing, the goal is we're starting a registry. So that'll be coming out in 2017. And you will sign up, you can select your privacy settings. So you can say, I want all my images to go to whoever is researching anything. Or you can say, you know what, I want to know who's doing the research and I want to read it before I agree to give you anything. But it's going to be an open source
Yeah. That'd be helpful.
registry, and it will be helpful. And through these, again, we did this list of suggested testings and all. You will be able then to come out with a gold standard because you're going to use a standard dictionary. You'll be able to come up with a standard of care,
Yes.
and you'll be able to test whether it works or not. So, like, this is the real start of sorting it all out in a methodical way.
Correct.
That's good.
Yes.
I'm glad to see you've learned something over a couple of years. You remember I'm one of your patients.
Yes, I do. I've missed a lot.
I still have a long ways to go.
Good.
Well, I never even heard of it until that, so, I mean, it's something I would have,
Yeah.
hypermobility, I mean,
That's been your,
like, I
Yes.
can't do that, I don't.
I was just gonna say, I found out 50 years later, after I moved cross country, took my big giant pile of discs and testing that from all different, and I put in front of a new provider, and I said, sorry, good luck. I have no idea, I'm kind of swallowing, bleeding disorders, joints, and she took like 10 minutes and looked through and said, pretty sure you have a connective tissue disorder. And she sent me to UCLA Genetics. And that's why I would say genetics is the place, because, they look at everything, plus they rule out other things. Like with me, they ruled out Marfan's, and then the type 4, the vascular. They did a full DNA, only because I signed over my DNA.
Sure.
So they did the $17,000 DNA that took 6
Yeah, I
months.
think you're right. I think
And they
that-
sent it to Cedars-Sinai.
Right.
Cedars-Sinai does have a bank of people with weird genetic things and that they're waiting as little orphans to find other people who have the same symptoms. Because I just have to sign all my stuff over to them. So
I think
I
even
think
there,
everyone's
that-
working
that-
together.
there may be
Right,
lots
that's
of
hard.
lots of connective tissue disorders or hypermobility ones that don't even still we can't fit them into which hole, and yet they are having hypermobility symptoms. But I think what that genetic testing does is at least it can help categorize the known ones, which one you belong to. There are lots of patients, at least talking to my other colleagues, there are patients that don't fit any category and yet they have some form of hypermobility. And where do you put those people? And I think registries like this will be very, very useful because, you know, genetics first starts with the clinical picture. And then once the clinical picture is perfectly boxed up, then you take each box and you say, well, what's the molecular biology of this and what's the genetic of this? So I think it's this registry because there are patients who don't really have the full-blown EDS looking like thing. They don't have the specific Marfan-like, but yet they have something bothering them, you know, which is hypermobile joint of one sort or another. And I've seen a patient go through like that, sent them to my other neurosurgery colleague, say, yeah, actually it's the full thing, but yeah, they have hypermobility. There's something there. We'd like to categorize that patient too, because maybe, like every genetic syndrome, you know, it's not cut and dry, you know, it's this variation. Even a single genetic defect has a variation on how it expresses itself. We know that. And the full-blown expression versus a slight expression, you know. So we know that exists, and that may be true in this, when there are this many types of collagens, and then on top of that, you know, it's like, oh my gosh. You know, you just walk around every day and you wonder how many are you missing. I see 50 patients on Friday, and the ones that I can't do something for, I always ask this question, and now there's this little list, you know, my nurse gets it. Any family history of dislocated joints to this, to that, just to kind of set me up. So if I don't have the answer, I could say, well, don't ignore it, maybe something. But you know, I think this registry is a superb idea, and I sincerely hope two things happen. That providers like myself and many others are participating, but I also hope that anybody and everybody who has this would fully give all their information. If not for them, their children, or their grandchildren, so that by the time the grandchildren have grown up, you know, we've sort of have a much better idea of categorizing these diseases, disorders.
Is that registry something that's standard in most, like for our library, would that be a standard registry that we would have a link to? I don't know.
So we were given a $25,000 grant to start this from Robert Wood Johnson. And we're starting it with this, it's a small thing to try and initially capture the group. And rather than ask you 100 million questions that somebody may or may not look at, which makes no sense whatsoever, we as an organization are going to capture your basic, who are you, how old are you, your demographics, basic demographics, how are you diagnosed and what are you diagnosed with, and a quality of life survey. Short, simple, to the point, so that when the providers come in and you have a question, you can go in and say, wow, this person has, you know, she's declining and whatever quality of life you can start. And then you can come in and say, here's what I want to study.
Okay.
Pick your pool of people that fit that group that you're looking for, and then you can participate in the study or not.
Okay.
And it will be from researchers here and all over the world. So it's going to be open source.
Yeah.
So what has happened in the past too, and it's kind of an academic problem, is that people guarded their information because, and it's,
Say it.
okay, so I'm going to say it. So
Speak the truth.
the truth is, they guarded it because that's how you got promotions and that's how you got recognized, by being the first one to come out with whatever it is. So you guarded all of your information and you didn't want to share with anyone. And that's changing though now.
Yeah.
So that's the good news is it's changing, and through doing an open source registry, we're sharing everyone's information with people who really want to find answers. And I think that's what's going to change it for so many diseases and disorders, not just us, but if we can push that forward as a community.
Yes.
Yeah.
I have 2 questions quickly. How have you found with the post-op care, with the pain control being so hard to really cover that pain with EDS patients, and how is the staff, like, have you been able to do it? And the second question is, how much, or have you been seeing a lot of, or any thoracic instability with EDS?
Yes. The answer to the second question is yes. I've seen it. I could have put 2-3 slides on that, how I've ignored it, and even tethering. I've seen thoracic cord tethering, maybe hyperflexible. Haven't ventured into doing the surgery for it yet. My senior colleagues, other people have done it. I'm not totally sold on surgery for that area. The pain control thing is a big issue. The first few patients that I did surgery on, it was a nightmare. I didn't know what to do. But now, you know, when I take the patient, let's say for surgery, there's 2 anesthesiologists who know these patients, these types of very well. And I just say, Susan Harvey's her name. I said, this is an EDS patient. She said, say no more. And so she just takes over, put them on a pain pump, and it really has, because every one of them has a different amount of pain medicines that they're taking, so she can do a conversion for them and really control the pain. But even there, we stumble, because then even on the floor sometimes not all the nurses know how to do it. It's a matter of time. At least it's recognized at my level and the anesthesiologist level. But it hasn't permeated to all. Even my colleagues sometimes, when they have a EDS patient post-op on a weekend, you know, to call them on Saturday morning. This one, when you walk in, that's not just a simple ACDF, okay? It's an EDS patient. They are quite miserable. Because they probably think like me, and I'll be honest, until 4 or 5 years ago, I was like, another crazy patient. I'm being honest, I'm just like, I know what you've been facing, so that's why I'm telling you what, but now I realize it's these patients have different category of pain level.
And we're probably just as crazy because we really don't know why. You know, why
That's
is it,
true.
why?
Well, that's true for any
So
personal
we might come out
illness.
crazy,
Yeah.
but we just really.
I think personal illness, you feel a lot better when you know why, even though nothing has changed, right? Because you understand what's going on, so at least I understand
The
why.
stress
I'm
factor
feeling
is gone.
Yeah, she said when she got her diagnosis, you know, she got in the car and was like, yay!
Then I started crying.
And then crying. Because I don't want
You don't
this.
want it, but it's nice to.
At least now they understand why.
Well, you can go on, now you can begin the process.
Right.
Before you have no process to start with. for
And
the
you have to
illness.
be your own advocate too, but you also, if you can, find someone who can. Because, like I said, I went to at least 3 to 4 for
Sure.
doctor appointments. Because again, I work in internal audit, we deal with controlled substances. We all know it's an epidemic, but somebody needs pain control, they need pain control. If they've got kids, they need to be able to take care of their kids.
Right.
Well, you know, when you get turned away so many times by a doctor and told, you know, that you don't have what you
Not
have, or that
everybody's
can't happen
intense.
to your body,
Right.
you kind of start thinking maybe you are crazy, or
Yeah.
you get, and I'm not a very stand down kind of person or get intimidated, but I was intimidated by doctors. So to actually have the diagnosis after a year, it's like, I can just go in and get treatment, I don't have to prove it, yeah, it's
Yeah.
pretty good.
Yeah.
Yeah, and when I say self-advocate, that's what I mean too. Like when I see my patients, the whole family's there. They're there for 3 hours with me. And I'm educating and I'm listening more than anything in those 3 hours. You know, I'll ask a question and I'll listen, and then we'll talk. And And that conversation just kind of grows, and they're telling you, you know, so many things that it's just like, oh, you know?
Right.
So, yeah. Awesome.
Well, I think we should wrap it up and thank Dr. Patel for really.
Great job. Yeah.